So our last speaker is Dr. Noah Scheinfeld. He is a graduate of Yale Medical School, and he is on the dermatology staff at Columbia University. He has a recently published review on Degos disease, which is available on our website, if I may offer a plug, www.degosdiseaseconference.org. And lastly, he is the author of the eMedicine online chapter that describes Degos disease. So thank you so much for joining us.
This really is going to be more of a typical dermatology presentation. I've already explained that this disease is really in search of a paradigm. And the bottom line is that when we don't understand things, at the end of science, like magic begins, and we come up with all kinds of explanations which are outlandish, crazy, kind of fantastic, and we need to bring the field back into science. And the understanding starts with science, and I think a lot of very interesting data has been brought forward today. It's always interesting when different specialties interact, because that helps to put things together. So I'm going to talk about a bunch of diseases which kind of share some overlapping feature with Degos, and hopefully that'll somehow kind of bring, perhaps, in a Zen koan-like way, some kind of shock of insight. So the first one is skin diseases with no factors, which interlap with lupus, of which Degos, of course, is one. Diseases with cutaneous and systemic variants, of which kind of Degos is one. White atrophic diseases that occur in the penis, of which Degos is one. Generalized non-infectious eruptions with disseminated coagulopathies, of which Degos is one. White atrophic diseases with coagulopathies, of which Degos is one. And round ulcerated generalized nodules, of which Degos can look like that. Collagen vascular disease, of course, we have the bugaboo of saying that Degos is lupus. Diseases with dermal mucin on biopsy, which Degos is. Diseases with interface dermatitis. Of course, this really is being given at the level of like a graduate seminar in dermatology, and unfortunately I seem to share the room with very few dermatologists, so you can always feel free to ask questions. Interface dermatitis is basically inflammation of a dermal epidermal junction, of which there are a number of diseases that have that. That for whatever reason the immune cells decide to take up residence there and try and erase the cells which lie along there. Nobody really knows why that is, in Degos or anything else. And lastly, we've spoken about the kind of genetic thing, and frankly, I think that tuberculosis has a genetic predisposition. In fact, most people who were very susceptible got wiped out in Europe in the 1800s. And frankly, hypertension is a genetic disease, but I just question whether or not it deserves to be, in the OMIM kind of category. So that being said, I actually had thought that I would give this presentation as the first presentation of the day today. So I just kind of went over some of these things of Degos, but we're going to skip this slide. And now we're going to go over diseases with no causal factors, which kind of abut on lupus. Again, this is Degos, and we're going to have a lot of great pictures because this is really how dermatologists like to give presentations. Again, the typical kind of white atrophic lesions, here in a Caucasian person, here in somebody with kind of tan skin, here a little bit oblong. And the disease which I'm going to juxtapose here is a disease called polymorphous light eruption that maybe none of you have heard of. It's a disease which typically kind of takes place in Northern European people. In Sweden, the incidence is as high as 5%. I actually have written a chapter on eMedicine about it too, and people in the United States kind of lambast me for overstating the incidence, but somebody published a paper in Sweden like that. It, again, is a photosensitivity disorder, which Degos is not, but the fact of the matter is that in a certain sense, people define polymorphous light eruption as a light sensitivity reaction, which is ANA negative, which is not lupus. And nobody has ever been able to figure out exactly what it is. It tends to come out as the days get longer and in the spring, and then as the summer comes on, it tends to go away because we think that the skin is hardened, although we really have no science to support any of these things. And both Degos and PMLE, are sort of in the category of the differential of lupus, and yet we really have no factor that explains why they occur in different areas of the body. Interestingly enough, both of them spare the face. And the point I would make here is that we don't really know all the players involved in inflammatory disease. Just because we haven't found a factor doesn't mean that there's not a factor, and maybe we need to have a more sensitive test. Just as an aside, although this really is not a dermatology group, there is a kind of pemphigus called pemphigoid gestationes, which has autoantibodies, which at one time they couldn't find. But then when they developed a more sensitive test, they discovered again that it was just in the pemphigus family. So again, let's go on to number 2, skin diseases with cutaneous and systemic variants. Well, we have a really good example. We have Degos, because in actuality, we know that Degos can be confined to the skin. This is actually a picture of the GI tract. This is a picture of somebody's lungs who has Degos, quite obliterated. For those people who are not dermatologists or rheumatologists, there's a disease called morphea that causes kind of white, kind of atrophy of the skin. And it just occurs in the skin, and frankly, it's not linked to any autoantibody or any factor. However, it can also be part of a constellation of symptoms called scleroderma that are deadly. Interestingly enough, on the dermatology boards, they like to ask the question, what famous person died of scleroderma? Does anybody know? What? That's correct. It's Paul Klee. He died of scleroderma. I don't know why they waste a question like that. But as you see, this is actually a picture of the kidneys, and the blood vessels basically are kind of homogenized in scleroderma. A picture of the kind of lung. The interesting thing about scleroderma, which it shares in common with systemic Degos disease, is really an unresponsiveness to therapy. Although there are any number of experimental therapies, is there anything new for kind of terrible scleroderma that's in the lungs? For the rheumatologist, yes or no? Cyclophosphamide is used, but it slows it down. Is that curative or? No, it just slows it down. It's like with pulmonary fibrosis. What? Is that Gleevec? Oh, it's interesting. So Gleevec is being used? Okay, interesting. Basically, that at least up until recently, that so-called progressive systemic sclerosis was a death sentence in the way that lupus, that Degos was systemic, although not really as quickly. Again, we really have no idea of why these diseases might be confined to the skin in one case and might be systemic in another. None. Zero. So hopefully somebody will somehow think about these two diseases and say, we don't know the checks and balances that keep the disease in place. And frankly, we're just a bunch of blind men. One person who says, well, I think they're really different diseases, and somebody else who says, well, I think that one is being held by checks and balances, or so on and so on. Really, I don't know, and I'm not going to tell you otherwise. All I'm going to say is that Degos is not alone in having cutaneous and systemic variations. White atrophic diseases that occur in the penis, well, again, you saw some of these slides a bit earlier today. This is a patient of mine. This was also a patient like this was published in the British Journal of Dermatology. Typical picture of lichen sclerosis, which is a disease which sort of overlaps with kind of morphea, but really has no systemic manifestations. I was speaking to the radiologist who gave a presentation. He had no idea what the condition was because it doesn't really involve the internal body. And this is a very interesting case report because in this kind of case report, it basically says that the histopathology of Degos looks just like lichen sclerosis. Frankly, nobody really has thought of lichen sclerosis as a vasculopathy or a vasculitis. In fact, nobody really has any idea of what it is. They just know it kind of leads to a homogenization of the collagen and atrophy of the skin. Who knows? Maybe they have more in common than we know. And maybe looking at the site differences might give us some insight. Again, we really have no sense of really site differences. We know that some diseases are more common on one area of the body than the other. A dermatologist by the name of Walter Shelley, trying to teach advanced dermatological techniques, would say, if you see something which doesn't look right, try and imagine it on a different part of the body and see if it fits there, and then kind of go back and think of what you're looking at. Again, we don't know why some rashes like the face and others like the penis. I would think that the penis and the feet and the hands and the nose would share kind of common features. I guess that most of you are patients, but sometimes people go into some condition called disseminated intravascular coagulation, which they just coagulate and they lose the peripheral areas, which include the nose and the hands and the feet. But somehow that pattern doesn't seem to be true here for Degos. Let's go on. Disseminated diseases without any infection. Well, look, people have talked about antiphospholipid syndrome, and earlier today I talked about how the head of dermatopathology at Mount Sinai said, Noah, I think that Degos is antiphospholipid syndrome without the phospholipids. Well, look, here's some pictures of antiphospholipid syndrome. First, you see this thing called levator reticularis, which is actually a normal finding in some people, but which can be with antiphospholipid syndrome, which is vascular mottling, areas of red with areas of pallor in between. You see kind of red hands, palmar erythema, and splinter hemorrhages. None of this has anything to do with Degos. I mean, I don't know, I've seen 6 Degos patients. I haven't seen any of this in them. And before I go ahead and make a fool of myself, do any Degos patients in the audience have these findings? I'll take that as a no. So here we see kind of Degos again, like more nice pictures, and again, very typical atrophy with a rim of telangiectasias. And again, this is antiphospholipid syndrome showing this kind of necrosis, just as occurs in Berger syndrome, involvement of some bigger vessels. Here's some pictures of Degos. Again, looks nothing like this. This never happens in Degos. This is actually interesting. I just like this picture because this occurred on the face. This was antiphospholipid syndrome that resulted in softening of the skin and outpouching. That's always interesting. So basically, while that for rheumatologists who look at vasculitis and classify things by the size of blood vessels, nothing really is so easy because you would think that antiphospholipid syndrome and Degos would have more overlap, and they don't. Why? We don't know. White atrophic diseases with coagulopathies. Well, we've already spoken about atrophy blanche. It's these stellate kind of lesions. This is a patient of mine who is of Turkish descent who came to see me. She had cutaneous Degos disease. I checked her stool for blood. It didn't have any. She seemed to go about her merry way. She was lost to follow me after 2 years, although I spoke to the dermatologist who referred them to me, and she's fine, just seeing another dermatologist. This is actually another patient of mine who had fatal kind of Degos disease. What's striking here is that all these are kind of round or oval. It looks nothing like atrophy blanche, and yet they're both white and atrophic. Again, a lot seems to be going on that we don't see in terms of location, in terms of other things. As we said, that atrophy blanche is really, if you look hard enough, you find that there's a coagulation defect. In Degos, that's not the case. Round, discrete, ulcerated nodules. Well, this is actually Kohlenheimer's reported case in 1941. Frankly, if I saw this picture on a dermatology board or on examination, I would not think of Degos. The disease I would think of is some other dermatological disease called lymphomatoid papulosis that causes these kinds of nodules. But nobody thinks of this as being a vasculitis or, frankly, anything related to Degos, and yet this looks kind of like it. This actually looks more like Degos because of the whiteness, but this just looks like a bunch of ulcerated nodules. So, frankly, they both share roundness. This is really a very important point because, frankly, we have no idea of why some diseases look like kind of round things, some look like oval things, and some are irregular. None. Zero. And that's really shocking because it really means that we don't understand how diseases come to be the way that they are. Psoriasis tends to be irregularly contoured plaques, but as the one dermatologist in the audience would say, there's a guttate kind of psoriasis that is a teardrop shape. We don't really know. Who knows? Maybe if we had that one piece, we could start to unravel the ball of mystery of Degos. I mean, why is that? Collagen vascular disease and Degos. Well, I promised this slide earlier. I mentioned that, but these collagen vascular diseases have been reported. I pulled the one case of scleroderma, and this was the lesion that they showed, which frankly looks crusted, but I guess that it sort of shares something with kind of Degos. Frankly speaking, to me, it's not surprising that collagen vascular disease can sometimes have Degos-like lesions. Frankly, it looks like anything. That like lupus, again, is a great imitator along with syphilis. And frankly, but Degos, I guess in rare cases, can be the end pathway of any of these. It's unsurprising. But what it is surprising is that Degos exists. It's so rare, it's so peculiar, cutaneous and systemic, very odd. It's hard to even approach the issue. Mucin in the dermis. Now, none of you are dermatopathologists, but you've heard mucin mentioned at least once or twice. I will show you some slides so we can illustrate it for you. That mucin is some kind of a cellular product, another patient of mine. And although these are not their kind of biopsies, that like mucin is this substance which is in the skin. You can stain for it. It's a product of cellular metabolism. Why it builds up in these diseases, nobody knows, not in a single one. And we have literally dozens of diseases in dermatology which have mucin along with Degos. What is so bizarre is that none of the existing theories of Degos, be it in a coagulopathy or a virus or anything, why should there be mucin, which is this deposition product, with a disease which really involves the blood vessels? Where is it coming from? And just to let you know, of course, that like lupus has mucin. This is a disease. This is not a rock band. This is called a disease called reticulated erythematous mucinosis, which basically is kind of these red things, these like red plaques with no real systemic things. Some people have related it to lupus because they relate everything to lupus, but it probably is just some kind of mucinosis, scleromyxedema, another disease, mycosis fungoides, which is a kind of cancer, and it has mucin in it. Where does that come from? I don't know. And a bunch of other diseases. And certain kinds of cancers can have mucin in them too, and dermatomyositis too. How it is that we hook up a disease which we understand to be a vasculopathy or some kind of a vascular disease with the presence of mucin, mystifying. Maybe mucin is really important. Again, I don't have any theories to back that up. Interface of vacuolar dermatitis. This is Degos. Again, what's really strange is that a disease which is affecting the blood vessels is somehow triggering this process at the border between the epidermis, which is this, and the dermis, which is this. Now look, you might say, Noah, well, that's not odd to me. I'll tell you why it's odd, because for the most part, interface dermatitis is thought to be an immune-driven process. For some reason, the white blood cells, the lymphocytes of the body are sensing some kind of antigen here, maybe here, and they're attacking the area. Interface dermatitis is a hallmark of lupus, and strangely of chronic graft versus host disease, where it's really thought to be an immune process, of dermatomyositis, of some kind of a drug eruption called a fixed drug eruption. In actuality, the most common pattern of inflammation in drug eruptions is actually an interface dermatitis. What that possibly has to do with Degos, nobody knows. More diseases in dermatology which involve this inflammation. Erythema multiforme, you've never heard of that. It's target-like lesions which might occur as a result of an infection with herpes, lichen planus, another disease, lichen planus-like keratosis, which is basically a reaction to like a sunspot on you. For some reason, the body perceives it as being foreign and it attacks it. More pictures of Degos which show the interface dermatitis. Again, our understanding is meager because it does not account for this, I guess, everybody thinks it's an immune phenomenon, but Degos isn't an immune disease. Maybe there are feedback mechanisms that we don't see. And there probably are vast systems, vast subterranean cities which we have yet to recognize. Finally, you've heard from the NIH that Degos might be influenced by kind of genetics. I don't think that person is in the audience, but I would just say that all diseases occur against a genetic background, but at least when I went to medical school, I thought of genetic diseases as like one gene and one disease and not just kind of genetics and odds ratios, but maybe I need to change my mind. I put up all the cases here of the 10 reports, some of which are not in PubMed, because I don't think that this one is in PubMed. It's from the Netherlands, and then I think that the other ones are probably in PubMed. Again, I think that there's probably a strong predisposition towards reporting these because they're more interesting. Whether or not this truly represents kind of 1/3 of Degos, I guess we'll have to see as we gather more cases. Well, I don't know if it deserves an OMIM number. Maybe it does. There is no question that genetics plays a role in it. And just as an aside for a paper that I recently wrote about ovarian carcinoma and the skin, I think that the concept of oncology and immunology and infectious disease and genetics will be collapsed one day as basically one unified thing when we actually see the elephant. Some closing thoughts. Well, I think that Degos is distinct, but it resembles some other diseases, but I think it stands apart. Again, I like Venn diagrams, and I put some of the conditions that we've talked about, conditions with kind of mucin, interface, dermatitis, atrophy blanche. I put Degos at the middle of this one, and lupus clearly can share a lot of features with Degos. It can have mucin, it can have interface dermatitis, it can involve dysregulation of complex system with autoantibodies, yet it doesn't really have these features. Someday we'll figure it out, but I hope it with your help. I would say that in the end, it really is only science. Diseases were mysterious until they become obvious. I don't know if any of you have read Susan Sontag's book called Illness and Its Metaphors, or AIDS and Its Metaphors. She speaks about the fact how tuberculosis was a romantic disease. It was felt to be a disease of the soul until finally the bacillus was isolated. How AIDS had a certain kind of romanticism until finally that the virus was found. Frankly speaking, we have a puzzlement. We have a conundrum in Degos. And frankly, it's hard to get your hands around it. There really are so many loose ends. There's really hardly a nexus at all. But again, I think that the overlap of complex systems that are operating continuously makes it seem as if there's a ghost in the machine. But frankly, it's only a machine. We don't hear all the crosstalk that is going on in the body. The body does a trillion operations every day. It's constantly communicating back and forth. That's why we don't just fall into a mass of jelly. But we don't hear the crosstalk. We don't hear the whispers. The Aborigines, are very sensitive to the land in Australia. When we Westerners kind of go there, we don't see what they see. And I'd say that someday when we have more sensitive tools, maybe we will hear all the crosstalk. But we don't, so it really is just really complicated, and it's hard to get your hands around it. What we see is not all there is. Again, there are vast cities, subterranean kind of countries that we have yet to recognize. And sometimes science is just basically kind of filling in the blanks. I was desperate to find a periodic table, because at one time they had them with this empty boxes where they hadn't yet found the elements, but they knew they had to exist. Sometimes science is like that, and sometimes it requires imagination. And I think that someday when the answers come, they're just going to come from like left field, from an oncologist or a hematologist, or a vascular surgeon, like none of whom really came to see us today, because they'll see something that we just can't see. And frankly, I hope that this meeting will cast a ray of illumination onto the enigma of Degos disease, and I thank you for inviting me.